Bismillahirrahmanirrahim. Hello friends. Today we will discuss about the peptic ulcers. In this lecture we will conduct about the introduction, pathophysiology, etiology and risk factor, type of peptic ulcer disease, clinical representations of the disease, investigation and diagnostic tests, complication of peptic ulcer disease, management and summary. Introduction about the peptic ulcer. What is a peptic ulcer? Peptic ulcer is a lesion in the lining mucosa of digestive tract, typically in the stomach or duodenum, caused by digestive action of pepsin and stomach acid, which is hydrochloric acid. Lesion may be subsequently occur into the lamina propria and submucosa to cause bleeding. Most of the peptic ulcer occur in either duodenum or in the stomach. Ulcer may be occur in the lower esophagus due to refluxing the gastric content, rarely in certain area of small intestines. Pathophysiology. When in the stomach there is defensive mechanisms which are bicarbonate mucus layer, prostaglandins, mucosal blood flow, epithelial renewal. If the defensive mechanisms decrease, so the chances of peptic ulcers can occur, and there is aggressive factors which aggravate the peptic ulcer disease are Helicobacter pylori infections, NSAIDs such as aspirin, pepsin, bile acids, smoking and alcohol can lead to peptic ulcer diseases. Under normal condition, a pathophysiology balance exists between gastric acid secretions and gastroduodenal mucosal defense. Mucosal injury and thus peptic ulcer occur when the balance between aggressive factors and the defensive mechanism is disrupted. Aggressive factors such as NSAID, H. pylori infections, alcohol, bile salt, acid pepsins can alter the mucosal defense by allowing back diffusion of hydrogen ion and subsequent epithelial cell injury occurs. Etiology and risk factors. Lifestyle. Smoking, acidic drinks, medication can lead to the peptic ulcer. H. pylori infections, 90% have these bacterium passed from person to person, fecal oral route or oral route. Age. Duodenal ulcer occur at the age of 30 to 40 years. Gastric ulcers occur over the 50 years. Genders. Duodenals are increasing in older women. Genetic factors. More likely a family member has his. Other factor, stress can worsen but cannot cause the peptic ulcers. Types. We have two types of gastric ulcers. Peptic ulcer. What is gastric peptic ulcers? One has duodenal peptic ulcer. Gastric ulcers are occur in the lesser curvature of the stomach. Duodenal ulcer occur at the duodenal parts. There is a diagrammatic representation of the gastric and duodenal ulcers. As I said that the gastric ulcers occur at the lesser curvatures of the stomachs, and duodenal ulcer occur uh, beyond the pyloric sphincters in the duodenums. Clinical presentations of the peptic ulcer diseases. Duodenal ulcer or gastric ulcer. Age, as I already mentioned, is 30 to 40 for duodenal ulcers, middle age 50 to 60 at the gastric ulcer. Duodenal ulcers are more in males, gastric ulcers are more in females. Occupational. Duodenal ulcers are stress jobs like manager in bank managers, etc. The jobs which are so stressful. As I discussed that stress is a factor which aggravate the peptic ulcer diseases. Gastric ulcers same. Duodenal ulcers, epigastric pain and discomfort. Um, Gastric ulcers, epigastric can radiate to the back of the. There is a clinical representations and signs and symptoms from which we will differentiate between the gastric ulcers. Onset 2 to 3 hours after eating and midnight. Gastric ulcer immediately after eating, aggravated by the hunger is the phenomenon is the differential point of duodenal ulcers aggravated by eating gastric ulcer aggravate. Relief by eating is done with the duodenal ulcer, gastric ulcer, lying down or vomiting can relieve the gastric ulcer. Durations of the duodenal ulcer is 1 to 2 months. Gastric ulcers can last for few weeks. Vomiting is uncommon in the duodenal ulcers, common to relieve the pain in the gastric ulcers. There is a good appetite in the duodenal ulcer patients. Patient afraid to eat because the pain is aggravated by the eating. So gastric ulcer patients are afraid to eat. Diet good, eat to relieve the pain. Duodenal ulcers, avoid fried food. Weight loss, there is no weight loss occurred in the duodenal ulcers, and there is weight loss at the gastric ulcers. Hematosis, 40% of the patient vomit, vomiting, and there are 60% of the patients of the gastric ulcers vomit with the blood. Melena, melena is a word used for this blood in this stool. 60% duodenal ulcers have melena, and 40% have gastric ulcer have melena. Investigation and diagnosis. Investigation, stool examination for fecal occlude bloods, and we can also uh, strain of the H. pylori organisms. Complete blood count CBC for decrease in blood cells. Diagnostic test, esophagogastroduodenoscopy, EGD. Endoscopic procedure, visualize ulcer craters, ability to take tissue biopsy to uh, read out cancer and diagnose H. pylori infection. Upper gastrointestinal series, barium swallow, X-ray that visualize the structure of the upper GI tract. Urea breath testing used to detect H. pylori. Client drink a carbon enriched urea solution. Exhale carbon dioxide is then measured. In all patients with alarming symptoms, endoscopy is required because there is a chances of perforation of the gastric ulcer, and there is caused gastric adenomas. Due to this, uh, patient with having dysphagia, weight loss, vomiting, anorexia, hemoptysis, or melena can done their biopsy. Complication of the peptic ulcer. Hemorrhage, blood vessel damage as ulcers erode into the mucosa of the stomach and duodenal wall. Coffee ground vomitus or occlude blood in the tarry stools. Perforations, as ulcers can erode through the entire wall. Bacteria or partially digested food spill into the peritoneum. Peritonitis, narrowing or obstruction of the pyloric. Swelling and scarring can cause obstruction of food leaving stomach. Repeated vomiting occur as a result of the narrowing and obstruction of the pyloric sphincter. Management, lifestyle modifications, hyposecretory drug therapy, H. pylori eradication therapy, surgery. Lifestyles, we have discontinued NSAIDs, smoking cessation, alcohol cessation, stress reductions. We can manage our lifestyle to a free stress lifestyle, and we cannot use alcohol, smoking, and discontinue if we are taking any kind of medication like NSAID sprints. So we can discontinue it because they are the aggravating factors of the peptic ulcers. Hyposecretory drugs are proton pump inhibitors, H2 receptor antagonists, and NSAID prostaglandin analogs, mucosal barrier fortifiers. They are the drugs which decrease the secretory of the stomach acid, so the peptic ulcers disease can not be occur. H. pylori eradication therapy, triple therapy, proton pump inhibitor, two antibiotics. And one we have used metronidazole plus clarithromycin, and one other we use clarithromycin plus amoxicillin. Surgical treatment indication: failure of medical treatment, development of complication, high level of gastric secretion and combined duodenal and gastric ulcer. Principal: reduce acid and pepsin secretions. Type of surgical procedure: gastroenterostomy, create a passage between the body of stomach to the small intestines, allow regurgitation of alkaline duodenal content into the stomach, keep acid away from ulcerated area. Type of surgical procedures: we have vagotomy, we cut the vagus nerve, eliminate acid secretion stimulus to the stomach. Pyloroplasty, widen the pylorus to guarantee stomach empty even without the vagus nerve stimulations. Postoperative care, NG tube care and management, monitor for postoperative complications. Postoperative complications like bleeding, duodenal stump leak, gastric retention, dumping syndromes, anemia, malabsorption of fat can occur as a complication of the uh, peptic ulcer disease, and we have to after the surgery. Summary: H. pylori is the most common cause of peptic ulcer disease and is a risk factor for gastric cancers. H. pylori eradication reduces risk of disease recurrence. Test and treat strategy is recommended for patients with undifferentiated dyspepsia. Initial evaluations with endoscopy is recommended for those with alarm symptoms or those failing treatment. Optimal treatment regimens are 14 days with antibiotic and acid suppressant triple therapy. Thank you very much. Stay tuned for the next lectures. Please subscribe my YouTube channel and press bell icon for daily latest updates. Thank you.